Welcome to today's APSC CME webinar on the use of MitraClip for mitral regurgitation, the when, who, and how. The date stamp today is the 21st of July on a Wednesday, 6 p.m. Singapore time. This APSC webinar is endorsed by the Singapore Cardiac Society, EBAC accredited for CME points in collaboration with Abbott. My name is Jack, and it's my pleasure to welcome everyone to today's webinar. I'm the president for the Asian Pacific Society of Cardiology, as well as the president for the IACP. We're very privileged to have two chairs today to lead the session discussion. My good colleague and friend, Professor KK Yeo, Senior Cardiologist, Chair for the Scientific Advisory Board at the APSC, and more excitingly, also the Chief Editor for the upcoming Journal of the Asian Pacific Society of Cardiology to be launched early next year. His co-chair is Dr. Takashi Matsumoto from the Shonan Kamakura General Hospital, Japan. So let's get started, and we'd like to invite Professor KK Yeo to start off by updating us on the APSC consensus statement recommendations on the use of MitraClip for mitral regurgitation. KK, please.
So let me present a little bit on the Asian Pacific Society of Cardiology consensus statements on the use of MitraClip for mitral regurgitation. My name is KK Yeo. I'm the chair of the Scientific Advisory Board for the APSC, and this paper has really been published in European Cardiology Review. These are my disclosures. Well, you know, the APSC convened a group of experts in this field to address the use of MitraClip for MR. And you can see from the list of experts here that we have both interventional cardiologists, echocardiologists, heart failure specialists, and heart surgeons across a broad spectrum of countries in Asia, often those with expertise in this technology or with cardiac surgery. My co-chairs are Drs. Takashi Matsumoto and Jack Tan, and I want to thank all of the members of this expert committee for their contribution to this paper. Please also note that we have included. I'm having trouble hearing you. We also included two speakers from the United States, Drs. Greg Stone, no stranger to anyone, and Dr. Joanne Lindefeld, an expert in heart failure from Vanderbilt in the United States. Now, for the consensus building, this was how we did it. We graded evidence as high quality, moderate quality, low or very low in quality. And the consensus building was conducted over several meetings, for at least one of them was prior to COVID, so we could meet in person. And there was online polling to see whether individual experts agreed with the statements, were neutral or disagreed. And based on methodology described by Belsham et al., we had a cutoff for consensus at 80% agreement or neutral. And those who disagreed were also had their comments reported separately. Now, I think one of the key components of this consensus document was to describe what was severe mitral regurgitation. And you can see on this figure, which we created for this paper, some of the key considerations. First, among them, left atrial size, pulmonary vein flow pattern, regurgitant volume, venous contractor, EROA, ventricular size, pulmonary pressures, etc. So I think this is very useful for simplifying some of the conceptual framework for what is severe mitral regurgitation. Now, let me go into some of the statements. First, we looked at MitraClip use in degenerative MR. The first statement is this: both symptomatic and asymptomatic patients with at least 3+ DMR who meet the indications for surgery, but who are considered high risk by the heart team, should be considered for MitraClip implantation. And there is a moderate level of evidence with a good degree of consensus, with 4% disagreeing. Statement number 2, MitraClip use should be considered for symptomatic high risk, at least 3+ DMR patients with or without reduced LVEF. And again, a fairly good degree of agreement. Statement number 3, MitraClip use may be considered for asymptomatic patients with high risk DMR with reduced EF and or LV dilatation. or 2, new onset atrial fibrillation, or pulmonary hypertension. So these are fairly standard statements. I think the key point is that we, first of all, had to have at least 3+ DMR, and the criteria which would enroll patients for surgery were allowed into indications for the clip, but only if they are felt to be high risk. So I think these were fairly, how to put it, the consensus was good in these 3 statements. Now, functional MR is a bit trickier, and let me go through them. Statement number 4, the MitraClip should be considered for at least 3+ symptomatic functional MR who are already on guideline-directed medical therapy. And FMR patients should receive at least 1 month of optimized GDMT with reasonable attempts to up-titrate treatment, as well as cardiac resynchronization therapy, defibrillator if indicated, before being evaluated for further intervention or MitraClip use. Now, there is a good level of evidence, especially from the COAPT study, and the level of consensus was high. I think this is worth a bit of discussion. First, I think we recognize that GDMT is the cornerstone of therapy for functional MR. Now, the question is it 1 month? Is it 2 months? Is it 3 months? We felt that we would allow for at least 1 month, bearing in mind that this is largely going to be a heart team discussion. We also use the words such as reasonable attempts to up-titrate treatment, because it is very hard to be prescriptive across the region with different access to therapies for medications across the region. Statement number 5, for ischemic functional MR, coronary anatomy and ischemia evaluation should be performed before MitraClip consideration. If PCI is performed, staged MitraClip therapy should be considered for severe symptomatic functional MR. Ischemic FMR patients requiring CABG for revascularization, concomitant surgical repair or replacement may be considered, and this one was a high level of consensus, 100% agreed. Statement number 6, FMR patients should be considered regularly. In this case, we suggested, for example, every 6 months, and referred early to the heart team for potential MitraClip implantation. Whether something or not is futile should be deferred to the heart team. Statement number 7, symptomatic patients with at least 3+ FMR should be assessed by the heart team for possible MitraClip implantation. This, I think, is primarily to make sure that our cardiologists and general practice physicians should be aware that there is now such an option available. FMR patients who do not meet the eligibility criteria for MitraClip implantation, for example, if they are at this point in time asymptomatic, those who don't have that MR, or those whose medication has not been optimized, should be closely monitored, and those who subsequently meet the eligibility criteria, in other words, if they are symptomatic or have those other criteria we mentioned a bit previously, should then be considered. Now, the next part of this is actually on the technical considerations for MitraClip use. More recently, the Americans have published some guidelines regarding what is a green light case, a yellow light case, or red light case. I think that is a separate discussion altogether. For our purpose, what we are talking about here are some of the technical considerations, and they are not exhaustive. There will be situations which don't fit in nicely, but I think these are representative. First, what is ideal pathology? Well, that is largely based on Everest 2 criteria, where the pathology is in segment 2, A2P2, where the valve area is at least 4 centimeters square, and if none of the complex or inappropriate conditions are present. What do we mean by inappropriate? Well, if there is leaflet perforation, active infective endocarditis, presence of moderate to severe mitral stenosis, and of course, if there is left atrial thrombus, these would be cases we don't want to do. The complex cases are more interesting because we might want to do, but maybe we don't want to do if the risk is too high. For example, when the disease is in segment 1 or 3, that is too medial or too lateral, where the posterior leaflet length is too short, that is less than 7 millimeters, where there's Barlow's disease, where there is a cleft, severe calcification, prior annuloplasty, or rheumatic valve thickening. In our center, and as I'm sure in all the panelist centers here, we have done all of these kind of cases, but they are not easy and not something we want to recommend for folks who have just started on this therapy. This is an important flow chart which we put in the guidelines, in the consensus document. That is, what is the assessment and initial management of patients with at least 3+ functional MR? Let me take you through that. First, coronary anatomy and ischemia evaluation with revascularization, if appropriate, should be performed. And we must have the heart failure specialist be part of the team to optimize medical therapy, plus minus CRTD. And if there is persistent symptomatic functional 3+ MR, FMR, we should consider the clip. Now, there is a statement in here that helps frame our understanding of what kind of echocardiography should be used. We think that the TEE, the transesophageal echo, is good for defining etiology, and the transthoracic echo is better for assessing severity, largely because during a transesophageal echo, patients are often sedated and fasted, and the volume status may make the MR appear to be less severe than it is in real life. So this is an important slide. We ended off the consensus document with a section on subgroups and special populations for MitraClip, and this include atrial functional MR, concomitant mitral regurgitation and tricuspid regurgitation, acute MR, and hypertrophic obstructive cardiomyopathy. So statement 9 is this: for patients with symptomatic atrial FMR, they should be evaluated by the heart team, which in this case should include the electrophysiologist and the heart failure specialist. And if treatment has already been optimized, the MitraClip may be considered. We recognize that there is low level of evidence, but the level of consensus was high. For statement number 10, the expert panel acknowledges that the MitraClip has been used in less common scenarios, such as what I mentioned, with reasonable reports of clinical success. But however, enrollment into clinical trials or registries is preferred, and patients with these less common conditions should be evaluated by the heart team on a per patient basis, with informed patient consent on the limited understanding available to determine whether the MitraClip use will be feasible and beneficial for them. What this simply says is we don't know enough, let's find out more. Patients need to have informed consent before we do the procedure, and pretty much everybody agreed with that. So that is the last slide here, and I'm going to pause here and stop the talk. I just want to again thank everyone on the expert panel for contributing to this document. We have 10 statements. I will perhaps after Takashi and Ningyan's presentation, we can then discuss it in the entirety of everybody's talk. Takashi, would you be ready with your slide?
Okay, let me share my slide.
Okay, let's try. Over to you, Takashi.
Oh, wait. Okay, can you see my slide? Okay.
Yes, and we can hear you well too. Go ahead.
Okay, so thank you very much again. I will present MitraClip treatment of moderate to severe and severe mitral regurgitation in high surgical risk patient. This is 1 year data, clinical data of MitraClip in Japan. So this slide shows footsteps of MitraClip. In Japan, the AVJ 514 Japan trial started 2015, and based on this result of this trial, it's approved in clinical setting in 2018. So this trial included enrolled patient 500 cases in Japan in real-world clinical setting. So introduction, the MitraClip is transcatheter mitral valve repair system that has been shown to be safe and effective in over 100,000 patients worldwide. The AVJ 514 trial was initiated in Japan in 2015 to demonstrate safety and efficacy of MitraClip in high surgical risk STS score over 8% patient with symptomatic moderate to severe or severe mitral regurgitation. So these studies demonstrated a meaningful improvement in eligible patients. As a result, MitraClip was granted approval for commercial operation in 2017. The Japan Post-Market Clinical Use Surveillance (PMS) was launched thereafter to monitor safety and efficacy of MitraClip and evaluate its real-world clinical outcome in Japan. So this slide shows a method of this trial. Design is a prospective multicenter single-arm surveillance study that enrolled first 500 patients across 40 Japanese sites between April 2018 and January 2019. Key outcome measurement is MR severity, procedural outcome, and major adverse event (MAE), the survival and hospitalization rate, and NHCS functional class. A primary endpoint was site-reported single leaflet device attachment (SLDR) rate at 30 days and acute procedure success rate at discharge. Follow-up time point was baseline procedure, discharge 30 days, and 12 months, and thereafter yearly. So objective is the primary objective of this slide. This trial is to report on the 1-year clinical outcomes associated with MitraClip device from a subject enrolled in the Japan post-market surveillance study. This is a study flowchart. At discharge, 483 patients visited, and at 30 days, 458 patients visited, and 1 year follow-up, 391 patients visited. This slide showed baseline characteristics. First of all, about 70% of patients had functional MR etiology. It's same as other countries, and the STS score is about 12%. It's very high surgical risk population. And prior heart failure hospitalization within 1 year, here this column is about 65%. And this is endpoint success rate. Acute procedural success, it is primary endpoint. It's 91.1% in all cohort, and 85% in DMR cohort, and 93% in functional MR cohort. And the 30 days single leaflet device attachment is 1.2% in all cohort, and 1.6% in DMR patient, and 0.56% in FMR patient. It's a little bit lower in FMR patient. And this is procedural outcomes. The total average number of clips is 1.46 clips in all cohort. And implant rate is 99.4%, and the device time is 94 minutes. And total procedure hospital stay is 20 days. It's based on, it's a little bit longer, but it's based on our clinical situation in Japan. This is MR severity through 1 year. Rate of MR equal 2+ or under 2+ is 93% at discharge, 92% at 30 days follow-up, and 88.1% at 1 year. It's durable through 1 year. And this is NHCS functional class through 1 year. At 1 year follow-up, it's the rate of NHCS functional class 1 or 2 is 93%. This is rate of mortality and adverse event at 1 year. It is about 15%. It's there's no significant change between DMR and FMR etiology. This is hospitalization rate. It's about 30%, and the same as other trial, expand all subject and expand FMR subject. This is a conclusion slide. This study represented the first contemporary report of 1 year outcome in primary and secondary MR patient treated with MitraClip NT system, not G4, in Japan under the Japan PMS study. This result indicates that the MR reduction obtained post-procedure was significant and durable through 1 year. The significant improvement was seen in functional capacity, mortality, and hospitalization rate at 1 year that were comparable or better than the outcomes from contemporary MitraClip cohort and expand study and TVT and MAS registry data. Thank you very much. This is the final slide.
Thanks very much, Takashi. So I think all of us will have questions for you, especially in conjunction with the consensus. But now I'd like to perhaps invite our third speaker, Dr. Wong Ning Yen from the National Heart Centre Singapore, good friend and a close collaborator on the MitraClip program in Heart Centre, to deliver his talk on the MitraClip G4 case, a case live in a box. Over to you, Ning Yen, please.
Hi, everyone. Can you hear me? Yeah. Okay, thank you for having me here today. And today I'll be talking about the MitraClip G4, the latest iteration of the MitraClip system, and case recording of its use. So the MitraClip has undergone multiple iterations throughout the past decade. The first iteration came in 2016, for which the MitraClip NT, the successor of the original classic MitraClip, had some new additions. It had steerable sleeve enhancements, for which allowed for more precise steering of the MitraClip. The gripper material was also changed to nitinol, with an increase in the gripper drop angle, for which allows for more active and efficient grasping of the leaflets. Next, in 2018, came the MitraClip NTR and the XTR system. Firstly, there were clip delivery shaft improvements. There was a stiffer shaft that allows for less rotation during clip advancement from the LA into the LV. There was also a longer clip delivery shaft of 1.5 centimeters, which allows for higher transeptal puncture, but yet allow for sufficient reach to the mitral valve. Next, there was also the ability to open and close the clip arms without locking the device, which reduces inadvertent medial and lateral movements during the process. And lastly, there were longer clip arms with the XTR system, for which allows for greater reach and for more complex pathologies. And now we have the MitraClip G4, which brought about 3 new parts to it. So first, there were 4 clip sizes. We have wider clips, longer clips. Second, there's controlled gripper actuation. And thirdly, integrated left atrial pressure monitoring. So in addition to the longer clip arms of the XT system, we now have wider clips, which are 2 mm wider clip arms, allow for 50% more horizontal coaptation. And now the NTW, XTW, together with the older NTR, XTR, we have 4 different clip sizes to tackle a variety of pathologies. Next, I'll show the live in the box recording, which shows discusses the case as well as the echo features to see which kind of clip selection will be best for this case.
And hi, good morning everyone. Welcome to National Heart Centre Singapore. My name is KK Yo. I'm the interventional cardiologist for the MitraClip program here at the National Heart Centre. Welcome again. Today with me in our live case demonstration is Dr. Wong Ning Yen, my partner in this program, as well as Dr. Yu Si Hui, who's our lead echocardiologist for the MitraClip program, as well as Sister Tina, who's going to be scrubbing in with me today, as well as Nurse Yurei, who's helping with this procedure as well. We have with us our anesthesiologist, Dr. Kenny Low as well. So with that, we're going to do this degenerative MR case. I'll have Dr. Wong here introduce the case. Dr. Wong, please.
So today we're doing a case of degenerative mitral regurgitation. So this is a 72-year-old gentleman, past medical history of hypertension and dyslipidemia. So he first presented with heart failure 2 months ago and was found to have severe degenerative mitral regurgitation from a flail P2. Coronaries were checked and there were no significant coronary artery disease. His case was discussed in our heart team, and in view of a calcified aorta, he was deemed high risk for surgery and hence referred for the MitraClip therapy.
So, Dr. Yu, would you please take us through the echo, and then we can decide which device to use?
This is a patient with what is clear to us a P2 prolapse with a flail cord that's attached to the posterior part of the valve. And in terms of hemodynamic, the MR jet is eccentric and is directed anteriorly. I'm going to show you the intercommissural view of this mitral valve. You can see the mitral valve in the middle of the P2 causing the regurgitations from the center part of the P2. Here, in the standard intercom view, we tend to do an X-plane, and this allows us to do segmental analysis of the mitral valve. And here I do a X-plane or the biplane cut of the middle part of the P2 that displays the P2 and the A2 on the right panel here. And it shows you that intermittently, as the heart is moving, the P2 part of the disease valve is showing a flail leaflet with a ruptured cord that's pointing anteriorly with the cord direction. And I freeze here to show where the pathology of the valve is, which again showing that this is the only problem with the patients causing mitral regurgitation, which is quite favorable for mitral valve edge-to-edge transcatheter therapy. Here again showing the regurgitations coming solely from the middle part of the diseased P2 prolapse. As a routine, we actually standardly do assessment of the valve. Here we cut the A1, P1, and then showing that the valve is competent. And similarly, we do an A3, P3 cut of the mitral valve, and again showing that the P2, A3, P3 scallop is normal. And then importantly, when we assess the mitral valve, we like to do the 3D reconstructions. And here you show a live 3D of the mitral valve looking from the LA, and the pathology is that of the prolapse in the middle part of the P2. I tend to look at the mitral valve both from the LA as well as the LV, showing whether there is any subvalvular pathology, and here it clearly sees that the mitral valve is moving very well apart from the prolapse P2 and the flail. On top of that, I think we typically like to quantify the mitral valve regurgitation, and here you can see that we are going to do a PSA, and the PSA quantifications allow us to really do a more standardized quantifications. And here you see the MR EROA is that of a severe range, 0.56 centimeters square. In terms of severity, we would also like to see the pulmonary venous flow pattern, but before that, for the transcatheter valve therapy, we like to see how big the size of the mitral valve is. And in that, one of the measurements is that of the mean gradient, and this is a standard procedure for us to do a pre and post clip assessment. So we need to get this. In here, we get a mean gradient of 1 millimeter per mercury, which is not elevated in the presence of significant MR. For pulmonary venous flow, you can see again here that is clearly showing systolic blunting, signify that the mitral regurgitations is significant, although it may not be representing a severe pathology, but knowing that the quantifications it's on the MR EROA shows is severe, I think when it comes to hemodynamic with the patient presenting with symptoms, it is clear that the MR is significant for the cause of the symptoms.
So Sihui, thanks very much for a very good description of the mitral valve. So in terms of choosing the W or the regular version of the device, what is the how do you call it, the prolapse segment width, and how would that help us make a decision as to which device to choose?
I think that's a very important question. I think just focusing on the mitral valve pathology, you know that we have got two clips size, the standard clip, which is the NT, or the long one, which is the XT. You can see in this case, the other consideration you have to think about is the width of the prolapse segment. And in this case, we actually measure that, and the width of that is about 1 centimeter, which is not too wide. And in terms of the valve anatomy, again, valve area that's small stops us from using a bigger clip. So in this case, again, the valve area, although it's not very big, but it is sufficient enough to put a clip. So in all considerations, knowing that the prolapse segment is not too wide and the flail width is again less than 1 centimeter, I think a standard length will be enough. The posterior leaflets, although not shown here, is not too wide or too long. So I think a standard with NT with a width, because it covers a bit more of the leaflets, will be sufficient.
Right, I agree with you. You know, I think the width of this flail segment would probably be just nice for a NTW. I think looking at the valve size and you know, the anterior posterior dimensions, or the I suspect XT would be too long for this annulus. Dr. Wong, what do you think?
Yeah, I agree too. So this is, if you see the case description just now, and there's a simple algorithm which gives us some little advice on how do we choose the different 4 different clip sizes. Some of the key considerations is the length of the leaflet, the width of the jet, and how big the valve is. So if the leaflet length is more than 9 mm, you can consider a longer clip, like the XT clips. If the jet is broad, then you use a wider clip. And if the valve area is small, then probably don't use something that's too long or too wide. Otherwise, you'll cause significant mitral stenosis. But this is just a very general recommendation. So next we have the controlled gripper actuation. So there is a little latch, this dark blue latch here, which actually latches both the livers together, which allows for either both simultaneous or, if you unlatch it, independent gripper movement. So usually we need to identify the gripper orientation before the clip enters into the LV. This is to identify which lever controls which gripper that is facing the anterior or posterior leaflet. I'll next show this live case to see how it works.
That's the posterior.
Yeah, that's great.
Okay,
yeah,
and we're going to lift it up again. And in this case, it tells us that the inner plunger is the posterior gripper.
The one with a little groove here.
Okay, and now he's going to test the anterior gripper.
Wait, I need to give you live.
Yeah.
Okay, so I got that already. Now
okay,
you go.
Good. Now he'll do the anterior gripper, which is not as well seen, but you can see drop.
Okay,
and now
wait.
it's well seen. Its anterior gripper is the outer plunger.
That's right.
It's lifted it up again. We're gonna.
So for this controlled gripper actuation, it's an additional feature, but eventually, I mean, simultaneous grasping is still recommended at all times. But it's useful in the point of verifying leaflet insertion. If you're not sure if, let's say, the posterior leaflet is well inserted, then you can just lift the posterior gripper and reassess that. Avoid grasping one leaflet and swing over to grasp the other leaflet, because there's a risk of pinwheeling or twisting the leaflets and causing a deformation and leaflet tear. And the last feature is the integrated left atrial pressure monitoring, which allows for continuous LA pressure monitoring throughout the entire procedure. So now we show the grasping and the final results.
This one?
Yeah, this one looks good. It's definitely resting. So Ningen, let's drop both grippers. Okay, we definitely have liftoff for both, and it's closing to 60 degrees. You definitely can see both grippers being lifted, and now we are 60 degrees. So now we verify, and we are happy, I'm happy, that we caught both leaflets. Sihui?
Yeah, I know. I don't have the sequence, that's all. Never
Okay.
mind. I think the most important thing is the... Okay, so it's a real sandwich that is lifting in between the gripper and the clip. Okay.
Yeah. So now we will close it. I think we can close it now. We'll close it a bit more to 20 degrees to max, and then you can do a MR assessment. Translate. So you just advance the touch just to remove a bit of the tension. So when you can, color will be good.
Okay. I'm just panning in and out.
Yeah. So in assessment of the MR, residual MR, it's really important it's important to scan in and out, because the MR jet, once it's been affected by the clip, can what do you call it, be eccentric and may come from funny angles. So it's important that the echocardiologist will scan and screen through different planes to evaluate that, like what Dr. Yu is doing now.
Yeah. So as you can see, as we pan in and out, just exposing more anterior and posterior cut of the mitral valve, it does look quite adequate MR reduction with no particular, we pay attention to whether there is any presence of PISA, because PISA tells us that the MR is definitely more than mild. I don't see any PISA head, as I would normally call them. And then in the long axis, I like to do that normally without explain, because explain to color reduces the frame rate tremendously. So we like to do it in the standard long axis with color. And again, going through how we should do the MR assessment, which is panning in and out. So panning one directions towards the posterior, and then more into the anterior. Rotation looks.
Okay, so that was our live in the box case, and now I'll just show a few slides of another case that demonstrate the utility of this different clip sizes and for the targeting more complex pathologies. So this is a case of this a very elderly lady with heart failure and has this degenerative mitral regurgitation from a P2 prolapse. So you can see here on the left side, you can see a very marked posterior leaflet prolapse causing a severe mitral regurgitation. And in this 3D on-pass view, you can see it's a very wide prolapse segment. And hence, for this kind of case, actually, a longer and a wider clip will be actually pretty useful. And this is what we use, MitraClip XTW. And on the right here, you can see the whole grasping process. You can see when the grippers go down, it can manage to capture almost the entire length of the posterior leaflet nicely. And even with such a marked prolapse, one XTW clip is able to abolish the MR, and with a residual trivial to mild mitral regurgitation. So in summary, we now, with the MitraClip G4 system, we have 4 clip sizes of varying length and widths to cater to a different variety of mitral valve pathologies. The control gripper actuation is a useful addition, but used with caution. And the continuous airway pressure monitoring provides an additional hemodynamic parameter to guide the repair procedure. Thank you.
Thank you very much, Ningen, and congratulations for very successful case, KK and Ningen and Siwi. So now let's start our discussion part. So is there any question from panelists? Okay, so can I ask one question for Ningen? So now we have 4 types of clips, NT, NTW, XT, and XCW. Which type of clip is you mainly use? In my institute, I use NTW in about 95% of patients.
Exactly like what you mentioned also. I think the most of our patients, we use the NTW clip for most of our pathologies. I'm not sure whether it's because for our Asian patients, the leaflet length may not be so long as compared to Caucasian. I'm not too sure about that, but we find that usually not so long clip, an anti-clip will be sufficient. But the wide clip gives us an option to use just one clip in quite a lot of the situations. Yeah. So our workhorse is actually the NTW now with the MitraClip G4. But as you can see, in certain pathologies like the one that I showed just now with such a long market prolapse of the P2, then the XTW will be pretty useful. Yeah. And manage to capture the whole posterior leaflet well instead of creating a hinge point if we use a shorter clip.
I see. So do you use XTW for a functional MR patient? In Western country, some doctor uses XTW for functional MR.
So far, all our functional cases we've been using NTW so far.
Oh, yeah. Same as me.
Yeah.
Kim.
Yeah, I have a question to Nin Yang. Yeah, for the MitraClip G4 system. So you already mentioned of the mitral valve area, small or larger, but there is no criteria in your slide. What is your opinion of some cutoff value of the mitral valve area to use the XT system in your experience? Yeah.
Yeah, so far, I mean, that algorithm is just a guide. Yeah, I don't think we actually have exact cutoff into the exact mitral valve area. Yeah, usually we visualize to see whether the whole mitral valve annulus, is it too big, or is it big or small? And usually we use also the mean pressure gradient to also guide top of the mitral valve area to choose which kind of clip size that we will use. But you're right, we don't really have exact valve area to guide in this. Yeah. Anyone have any comments on this?
Okay.
I was just going to say it's a difficult situation because the valve area is one thing, but the pathology is another. So, for example, if you have a very wide prolapse, you may need two clips, in which case you have two options. You can either put in two clips or one NTW or one XTW. But if the valve is smallish, kind of 4-4-5, then your options, you may be forced to just choose a W system. If the annulus is small, and you're worried about tearing the valve, then probably NTW. So I think the conceptual framework is there. I saw a live case recently where I would have chosen a NTW, but the operator chose the XTW with good result. And I think the field is still learning, and I think that's why studies out of the US and Europe, such as the EXPAND registry, are so helpful in framing our understanding. But I think it's an ongoing conversation. My thoughts about this have changed and evolved with time.
I see. Sometimes we face a very when we treat a small Asian person, we face a very difficult situation. Valve area is very small. It's 3 to 3.5, but jet is wide. Do you use NT or NTW in such case? KK or Ning, do you have any comment?
For the small Asian, especially the ladies, I generally would see how long the posterior leaflet is. Sometimes that becomes the main headache that we have, and also the leaflet quality. I think above all, we are worried about leaflet tears. So in general, we have stuck to our main workhorse of NTWs. I'm also curious to see what our other operators in this area, maybe Angus also has. And, what do you do? I mean, do you have a personal preference?
Yes, I fully agree with you, KK, because a few years ago when we just have launched the NTR and XTR, we were so excited to have XTR, especially with patients who have functional MR. XTR really was the game changer. And when it's come to the G4, we believe the XTW will be our main tools in treating these patients. But finally, we found that we very coherent with your experience. We found that NTW will be our to-go size, because we found that a lot of time when especially in elderly ladies, small size or elderly patient, the gradient really goes up, and the valve area is not sufficient to put in a second clip if we really use it just with XTW, but initially we planned to use two clips. Yeah. Another issue is the single leaflet detachment. We have a bad, rather unhappy experience with a patient who have prolapse, very severe fail posterior leaflet. We put in an XTW, but 2 months later, the patient have a delayed single leaflet detachment. Most likely it's due to the quality of the leaflet. So we were a little bit cautious about using the XTW right now. And from our experience, the NTW seems to be better for our patients.
I see. So I don't often use XT or XCW. Do you have any tip and tricks to use XT and XTW? It seems like that we need more height, and seems like it is hard to get very beautiful images of arm by echo.
I think we actually were very close to Ninian's opinion. Whether you use an NT or XT or a W or regular size will really depends on the valve area and the leaflet length. But I also agree with you that that sometimes it will be difficult to visualize the whether we have adequate grasping leaflet inside an XTW, especially it's really big, and it will be particularly difficult because last week we have a case of putting one very severe P2, P3 prolapse with more than severe MR. We put in an XTW, and then we want to, but the leakage is still very severe, so we want to put another XT regular. But the visualization is really difficult because of the first clip was quite big, and we need to put 2 clips really close together to minimize the regurgitation. So the imaging may be tough for our echo guy if we need to put in 2 XT device.
So CV, do you have any comment about the echo images? The difference of echo images between NTW and XTW?
I think it is really depending on the patients and whereabouts you place the first clip. So sometimes I find that if the first clip is lateral, and then when you go for a medial clip, it will be difficult. And I think sometimes, from what I can gather, is it really depends on the ultrasound beam and whether it is kind of just above where the your catheter is. So you might have to go off axis, and I do think that an X-planes helped a lot. X-planes allows you now to do off axis and angulations that we don't used to have in the past. So those will be some of the tricks that I think will be helpful. And the truth is on the table, and we just have to kind of get off axis.
I actually have a question for John. John, as a cardiac surgeon, when you look at this procedure, for functional MR, does it make sense that fixing the mitral valve would help the patient? The surgeons, have through the years worked on the functional MR, and it as a large group, as a general statement, it does not seem to help isolated functional MR. What are your thoughts looking at this therapy? Why do you think the CREP trial was so beneficial from a surgeon's point of view?
Yeah, thank you, KK. I think there are several parts to these questions. The functional MR, I think we have seen from the COAPT trial, which showed a benefit in survival. And whereas in the MitraFR trial, there was no benefit in survival. So it is of course, we're analyzing the trials in a bit more detail. So as you know, functional MR, in terms of getting rid of the MR, I think the MitraClip concept will work, because the way we treat functional MR surgically is to put in an undersized annuloplasty ring. But at the same time, in those who have a lot of leaflet tethering, we do use the edge-to-edge repair as well, or the alveolar repair, which essentially is the MitraClip. We don't do it routinely, but in those who have a lot of leaflet tethering, we do add that as an additional repair technique in addition to an annuloplasty. So to me, looking at the MitraClip, the best forms of repair is actually the best forms of lesion is actually the functional MR for using the MitraClip in terms of reducing the MR severity. Whereas in the degenerative, you do depend on a lot on the amount of leaflet tissue. And from the years of mitral repair I've done, these unfortunately tend to be in the younger patients. The younger patients do tend to have more excess leaflet tissue, who will be more suitable for the MitraClip in terms of reducing the MR. Of course, these patients tend to be the lower risk patients in whom the results of mitral valve repair surgery is proven for many years. In the higher risk patients, the elderly patients, typically you do not have much excess leaflet tissue. Often these are just due to a ruptured cord. And in these patients, there's not much excess leaflet tissue. So those patients are usually not so good in terms of the MitraClip to reduce the MR severity. But in terms of the risk, they are higher risk, they'll be more suitable for the MitraClip. So it's a bit of a difficult situation in that the patients most suitable for the MitraClip in terms of its success rate are the lower risk patients in whom you do not have the long-term results, whereas the patients most suitable are the younger patients. The patients less suitable are the older patients. But in terms of functional MR, which was your question, the primary treatment in functional MR is the left ventricle. And nowadays, with all the medical treatment, the Entresto, the SGLT2 inhibitors, resynchronization therapy, those must be the first priority. But at the same time, if the MR is so severe, then the MR will prevent the reverse remodeling. So in those who have a lot of MR, and we're not talking about moderate MR, I think those who have MR out of proportion to the LV dilatation, then the MitraClip would help, because if you get rid of the MR, then it allows the LV to reverse remodel. And so patient selection is important. And I think that explains the difference between the results of the MITRA-FR trial and the COAPT trial, because in the COAPT trial, they've already tried optimal medical therapy. There's still significant MR. So they get rid of the MR, then the LV is allowed to reverse remodel. Whereas in the MITRA-FR trial, the MR was severe, but it's not that severe, and they're not optimized them on medical therapy for long enough. So that's why there is a disparity in the results between the two trials. So I think functional MR would be the perfect sort of valve lesion for the MitraClip, but after having tried optimal medical therapy.
Yeah. Yes, as John told, optimal medical therapy is very important when we see a result from a COAPT trial and MITRA-FR trial. But at the same time, the definition of optimal medical therapy is very difficult. Sometimes we face what is the maximum dose of each drug, and we should introduce CRTD first or not. Do you have any comment, David, about baseline medical therapy and CRTD?
For optimal medical therapy, you're right, it's a bit tough because the so-called the development of the drug is so fast nowadays. Like what is valid 2-3 years ago is probably not valid now. So I would say for me, optimal medical therapy is you need to have a 4 pillar of heart failure drugs. That is, the patient need to be ARNI. ACE inhibitor is not the same as ARNI. All right. So anyone ACE inhibitor to me is substandard care. SGLT2 has to be on board as well. MRA has been on board as well, and lastly a beta blocker. If these 4 agents are not attempted or not tried in the patient, I think it's very hard to say that this patient has been optimized. And now we have other agents as well. When they admitted, we also give intravenous iron, but that can improve their symptom as well. I think, later this year, we're going to get another new drug, the vericiguat, targeting the cyclic GMP pathway. So for heart failure, we have a lot of drug, but minimum for me is you need to have a 4 pillar that I previously mentioned, and the dose must be, optimized before we say we give out on it. And we still don't do well. We usually will, we will not drag for months. After 2-3 months, they don't do well. If they're blood complex, we'll refer them to EP for either ICD or in a blood complex setting, a CRTD. And there are some group of patients who, despite doing all this, they will still have a symptom. What we do objectively is we do look at the NT-proBNP. If you know you can't get NT-proBNP down to less than 1,000, usually this group of patients are not going to do well. So this group of patients, if the MR is severe, I think they will be good candidate for MitraClip, provided they have contractile reserve. Like John previously mentioned, you also don't want to look for a group of patients that is beyond beyond remodeling. There's nothing to remodel. The heart is all blown up, 8-9 cm kind of heart, ejection fraction 10-15%. That group. So those group where they still have contractile reserve, ejection fraction not too bad, but yet despite optimal medical therapy plus minus CRTD in some patients, they still don't function well. I think that group will be an ideal group for MitraClip, because I'm also not going to offer someone a heart transplant or left ventricular assist device if the ejection fraction is about 30-something%. But this group, some of them, we know that there's still a lot of symptoms. So I think they will be good. Where somebody 15% right from the start, I think that group is probably too sick. We probably even have problems starting any medical therapy. They're probably too sick with a low blood pressure.
Thanks, David. Jokson, you were going to ask a question, I believe, just now.
Yeah. So I have one question, to either some faculty or speakers. So I think one of my question is regarding for the when to stop the procedure, when is the ideal timing, especially for some functional MR. For example, sometimes we just applied one clip, then MR grade decrease 1 or just 2, between 1 and 2, then there is a residual MR. But transmitral gradient is good, right, around the 2 to 3. Then what is your opinion to proceed more another clip to decrease more less than 1 or trivial, or just leave
so is
the
this
procedure?
for functional MR or degenerative
Just a functional MR, because we have some experience for the functional MR. There is some residual MR, because as you already told another faculties, just functional MR is a ventricular disease or atrial disease. So that means that there is a possibility to progress in the future. So
that's a really good question.
Yeah.
Takashi, do you want to?
Yes, that is very important question. But I think first of all, we need to check a type of residual jet. If jet is very eccentric, it says there is a shoot prolapse, residual shoot prolapse. If when I see such a coaptation gap, I deploy one more clip. But if the coaptation is good and jet is very straight to not eccentric, I leave that residual jet. If it's 1+ or 2+, there is a chance to decrease that MR jet with medication.
But what about CV from the echo point of view? How would you help the proceduralists decide or help decide together?
Yeah, so I think no questions about degenerative MR, because it's very straightforward to me. When there is a residual prolapse or when there is a residual pathology, you got to go after it, provided if there is enough space and the gradient allows for an additional clip. So I think for degenerative, it's not a question. Now, for functional MR, is a bit tricky because, as you know, functional MR is dynamic. It is very load dependent. So when the patients come out, when they go back to the normal state, the blood pressure will go up and the MR will increase. So sometimes, to be honest with you, we do multi-parametric approach. So to me, I think the most important is reducing the MR with a pulmonary venous flow that is very favorable, i.e. from reversal to systolic blunting, that will be the minimum I accept. I would like to see systolic predominance because that tells me that the LA pressures has been abolished. Number two, I look for the residual MR jet, which Takashi has already alluded to. If the MR jet looks like as broad, for example, if you see PISA or flow conversions coming on, you can't leave that alone because you know that when the patients come up in awake situations, it's going to get a lot more. And it doesn't help with remodeling of LV after MitraClip. We want to achieve 2+ and below. Next, we also look at the blood pressure. If the blood pressure is lowish, we may sometimes increase the blood pressure with the help of these physiologies and drugs to bring it up to something about, say, 130 or 140, because that helps us see what will be the blood pressure, what will be the MR in that kind of normal state. So those will be what I do. And of course, you know, you try to abolish the MR without increasing gradient. So checking your mitral valve area, checking your the residual gradient will be very helpful. It's a long-winded question to answer, but
yeah, Angus, do you have anything to add beyond what CV and Takashi mentioned?
Yes, I fully agree with them. And occasionally, because a lot of times this patient, especially functional MR, their blood pressure may be a little borderline, especially after general anesthesia. And this is not quite common when we put in 1 or 2 clip. And before we assess the severity of MR, we will routinely ask our anesthesiologist the blood pressure of a patient. And quite commonly, we got the reply of actually blood pressure, it was better after putting a clip. The blood pressure will increase after we put in the clip, and that might be a good sign that signifies we have increased the forward flow and increased the cardiac output of the patient. Of course, sometimes it might depend on the fluid status because these kind of patients, a lot of time they may be a little bit dehydrated. We want them to be dehydrated so that they don't have a lot of chest symptoms. Sometimes we might also, after putting the 2 clips, before we decide to withdraw the guiding catheter, we might give the patient a little bit more fluid just to make sure the severity of MR is really reflect the normal usual status.
There is thanks very much, Angus. There is a question in the Q&A, and I'm just going to read it out. The question is, can the MitraClip increase a patient's survival? I think it depends on which group and you were talking about. So in the degenerative MR group, the Everest 2 trial compared patients who were eligible for surgery for degenerative MR as well as functional MR against the MitraClip. And I think the reason why this is important is because at that time it was felt that it is unethical to compare with just medical therapy alone for degenerative MR when there is an established indication for a treatment that prolongs life and survival. So in that setting, there was no difference in survival, and therefore, by imputation, the MitraClip will prolong survival in patients who are not suitable for surgery, who have severe degenerative MR. There's a long roundabout answer, but I think that answers the first part, which is the MitraClip does prolong survival in appropriately selected high surgical risk patients with severe symptomatic degenerative MR. Those would be indications. The second group of patients would be those with functional MR. And notwithstanding what John mentioned about the differences between the COAPT and the MITRA-FR study, the COAPT study, which I would argue is a more robustly performed study, was able to show that in appropriately selected functional MR patients, those who meet the trial criteria, there was a benefit in terms of survival as well as symptom relief, among other things, for those treated with the MitraClip compared to GDMT alone. And the number needed to treat for that cohort was 5.9, which is a rather impressive number. So the answer to your question is yes, but key thing is in appropriately selected patients and not for all comers. For all comers, we don't have the answer to that. So I think as we come to the end of today's session, I think it's important that we maybe perhaps summarize a little bit the key findings for today's talk. I think you remember earlier on from Professor Jack Tan's introduction that we now have an Asian Pacific Society of Cardiology consensus recommendations for the use of MitraClip, and we have 10 statements, and I think there is broad consensus. I would say that the document is open access, so you can download it, have a look. We also have some of the latest data available discussed in that particular document. We also have seen the data out of Japan, the largest site for MitraClip use in Asia currently, from as in a talk given by Dr. Matsumoto. And lastly, from Dr. Wong, you heard about the new G4 system, which expands the treatment options available for our patients. And then with that, I think it's we are just exactly on time. I'd like to thank my co-chair, Dr. Matsumoto, our speakers, Dr. Wong, Dr. Matsumoto, and our panelists for joining us tonight at the APSC webinar, and also to our supporters with Abbott Vascular for supporting this session. With that, thank you very much and have a good evening. Stay safe, everyone. Hopefully the next time we do this, we'll all be in person. So take care and have a good night. Bye-bye.
Bye.
Bye. Bye.